So, good evening. Again, we are talking about competency 1.6 only. Last time we discussed about absorption. Last time we discussed the distribution, and today we'll talk about another important topic, that is biotransformation. Biotransformation is considered a very boring topic because we feel that some chemistry is involved, equations are involved, but I think it is important to have practical knowledge of these reactions which are taking place in our body. In biochemistry also we have to remember these equations. So whatever is essentially required, we'll talk about that today. So if we see what are the questions asked about biotransformation, right from what is biotransformation, why biotransformation takes place, what happens to the drugs because of biotransformation, which are the biotransformation reactions, which are the phases of biotransformation, what is the difference between phase 1 and phase 2 reactions, what are the factors affecting biotransformation, what is microsomal enzyme system, what is microsomal enzyme induction, what is microsomal enzyme inhibition, what are the consequences of microsomal enzyme induction and inhibition. So all these questions are related to biotransformation. If the short note comes, write a short note on biotransformation, then it is best. You can write whatever you know. But nowadays teachers, they have started becoming slightly specific, and so we have to consider every aspect of biotransformation. So first of all, what is biotransformation? We can define it like it's the process by which the drugs are converted into a more water-soluble compound. Remember, if the drug is already water-soluble, nothing is required, because we should remember one thing, that for absorption it is important to have lipid solubility, but for excretion of the drug, water solubility is required. If a drug is highly lipid soluble, you cannot excrete this drug. It would keep getting reabsorbed from the sites of excretion, from kidney, from bile. It will again be absorbed through intestine. So if you want to excrete a xenobiotic, as I keep saying that for our body, all these drugs are xenobiotics, they are foreign chemicals. So our body wants to protect itself, does not want any change because of this chemical, so it will try to get rid of this, and for doing that my body knows that it has to be more water soluble, then only it can be excreted. So that is the purpose of biotransformation, to convert a lipid soluble drug into a water soluble compound. That is the definition. Now what happens as a consequence? Because we keep saying that metabolism is to detoxify the drug, metabolism is to detoxify the body. That is not the purpose. My body does not know what is detoxification. My body knows only to get rid, it has to be water soluble. That's all it does. But as a consequence of this change, the drug may become more active. Because I still remember in our times we used to have this famous tag that was wrong, that biotransformation is a mechanism by which the drug is converted into inactive compound. No, it is not necessary. My body is not able to identify whether it is active or not, because the organ that is doing biotransformation, mostly it is liver, though it may take place in intestine also, in lungs also. in other places also, but mostly it is liver, specialized organ. It cannot identify whether it is an active drug or a passive drug. So it can only convert it into a more water soluble compound that may be more active, that may be less active. And we have examples of both. See this. This is active drug and this is equally active metabolite. So nothing has changed in the drug. We have an active drug and the metabolite is also active. That is as a consequence of, but these are examples I have taken from good old books. I also remember them when I was doing MBBS. Like say primidone, phenobarbital. In good old editions of Satoskar, you will find these examples. So primidone, this was very important drug in those days. So it gets converted into phenobarbital. Diazepam gets converted into oxazepam, desmethyl diazepam. This is the example we used to give. Digitoxin gets converted into digoxin. Imipramine gets converted into desipramine. Amitriptyline gets converted into nortriptyline. So these are examples that you have to remember. Always I keep telling you that whenever you are describing something, always describe it with examples. So these are examples of how an active drug gets converted into equally active metabolite. So it is not true that metabolism converts an active drug into inactive drug. It is not true. Now this is another example. We keep giving these examples also, that a active drug, this is active metabolite only, prodrug. So the drug in itself was not active, but the metabolite is active now. So the drug has become active as a consequence of metabolism. These are also classical examples. Levodopa gets converted to dopamine. Levodopa is not effective, dopamine is active. Enalapril, enalaprilat is the active form. Dipivefrin gets converted in the body into epinephrine. Prednisone gets converted into prednisolone, that is active. Sulfasalazine gets converted into 5-ASA, 5-amino salicylic acid. So these are classical examples that I am giving since 30 years. Yes, it is 26. It's been 30 years since I am teaching this topic. This was the very first topic I conducted seminar as a PG student. So it's been 30 years. So these are the examples I am giving since then. There is nothing new about them. Mercaptopurine gets converted into methyl mercaptopurine. Acyclovir gets converted to acyclovir triphosphate. So these are all classical examples. This is about first pass metabolism. We have talked so much about first pass metabolism. I am not going to spend more time. First pass metabolism means metabolism before the drug enters the systemic circulation. These are the examples. These are drugs with low first pass metabolism. These are intermediate. They are of not much use to us. These are important for us. Drugs which are having high first pass metabolism. And these are the drugs, because of first pass metabolism, they are not given orally. We know lignocaine, isoprenaline, hydrocortisone, testosterone, we don't give them orally because of first pass metabolism. And these are the drugs, though there is first pass metabolism, still we give very high doses. We give classical example of propranolol, 1 milligram IV dose, 20 milligram oral dose, 40 milligram oral dose. Similarly, if you see other drugs also, verapamil, if you see injection, it is available, we give 5 milligram, at the most 10 milligram, and when we give orally, we give 100 milligram. So what we do, we give large quantities of these drugs, but we do have oral preparations. Morphine, if you give IV, the quantity you have to give is very less. If you give orally, you have to go start from 30, 60, more than that. So these are examples of drugs which are having high first pass metabolism. So this is also metabolism, and mechanism of first pass metabolism is also same, just like biotransformation. Now, which are the reactions? Okay, before we go to reactions, which are the enzymes involved? Remember one thing, biotransformation may take place without enzymes also. That we call Hoffman's reaction, and we give classical example of atracurium. What is this Hoffman's reaction? The molecule rearranges itself. When it enters in the body, it rearranges automatically. So the structure of the molecule changes automatically without any enzyme involvement. But that is an exception. Hoffman reaction, just like I told you, I can give you one or two examples. Atracurium is one of them. Again, since so many decades we are giving this example. But routinely, biotransformation, as I told you, takes place in liver, because in liver there are specialized enzyme system, cytochrome system, and it's a big huge family. Smooth endoplasmic reticulum, these cytochromes are available, and it's such a big family that we classify it. And for classification, what we do, we write in the beginning 3 letters CYP followed by a numeral 1, 2, 3. 3 numerals are there. After that, alphabet A, B, C, D, E, F, like that, and then followed by another numeral. Innumerable. So many types of families are there, but what is important for pharmacology? Hardly 6-7 of them are important. 3A4, 3A5, most important. CYP 3A4, CYP 3A5. You have to find out some mechanism to remember which are the drugs metabolized by which family and which are the inducers and inhibitors of this family. If it is not possible, then you have to remember at least in general, which are the enzyme inhibitors and which are the enzyme inducers. Like 3A4, 3A5, most of the drugs are metabolized by these two, followed by 2D6. So these two enzymes, these 2-3 enzymes, they cover almost 85-90% of the drugs. They are metabolized by these enzymes. So which are the inhibitors and which are the inducers? So as I told you, you can remember in general. You can make some mnemonics or whatever, but this is very frequently asked question. Name some enzyme inhibitors. So they may not ask you which are 3A4, and even if they ask you, if you remember in general and you answer that, it should work. Yeah, unless specific some enzyme inhibitor is there. So that way you can remember. Some of them are very important, like grapefruit juice. In general, I am talking about ketoconazole, itraconazole. They are azoles. Erythromycin, macrolide antibiotic. Ritonavir, it's a protease enzyme inhibitor, na? So you can make some mnemonic or something. Another drug, Verapamil, and this actually you can remember, even diltiazem is there. So they are CCBs. Calcium channel blockers, except dihydropyridines are not. So these are Verapamil and diltiazem. They are non-DHP calcium channel blockers. And one more, fluoxetine. And nowadays, this was not there when I was doing MBBS. They became popular after that. So now you can add them also as S in the mnemonic. All SSRIs, most of them, paroxetine, fluoxamine, they are all sertraline. You will find them somewhere. So selective serotonin receptor inhibitors, that also you have to. So these groups you have to map somewhere in your mnemonic, whatever you want to make. But these azoles, they should be there, protease inhibitors, SSRIs, calcium channel blockers, verapamil and erythromycin macrolides, erythromycin macrolides. So these classes of drugs you will have to remember. Similarly, in inducers, BPGC, NAIR, whatever you want to remember, barbiturates, phenobarbital you can remember, phenytoin. So PP, BP, whatever you want to say, and GC, glucocorticoids and carbamazepine. These two are important. Rifampicin is very important, and nevirapine, efavirenz, both of them, they are basically NNRTIs, non-nucleoside reverse transcriptase inhibitors. So these classes at least you have to remember. So you make mnemonic or you do whatever you want. Sometimes it is easier to remember, just like I told you, BPGC, NAIR, need not go for a very complicated mnemonic, but you have to keep in mind that these are because you will keep referring them again and again. So you have to have some mechanism in your brain to remember them. And then if you remember them this way, then auto inhibition and auto induction also you have to remember. Sometimes it is asked. I have not written here, but barbiturates also are metabolized by 3A4, 3A5, and they are inducers also. So with time, if you start giving barbiturates, you will have to increase the dose. Tolerance develops. Similarly, if you see here, verapamil is one of the inhibitors, and you will find verapamil here also. Must be there. Verapamil is metabolized by 3A4, 3A5 only if it is not there. So auto inhibition also may occur, that gradually the effect will increase. So it happens with verapamil. So these things you'll have to remember. And one more important thing, it is not included here, that is oral contraceptives. 3A4 and 2D6 both are involved in metabolism of oral contraceptives. So that is why I'm telling you, because this is a question that is asked. A person, lady is on oral contraceptives, then she starts taking barbiturates, and because of that she becomes pregnant. What is the drug interaction? This is a very common example being asked since so many decades. So that is also there. So you will have to remember that most of the drugs, you see here fluoxetine is there, and here also fluoxetine is there. So fluoxetine is an inhibitor, auto inhibitor we would call it. So, and fluoxetine, paroxetine, venlafaxine, these are other antidepressant drugs. So when we are giving fluoxetine, it affects the metabolism of all other such drugs. So these are the things, if you remember them, you will remember them for a longer time. 2C8, 2C9 is another, 2C19 is another important, and 2E1, alcohol, halothane, paracetamol. So these are some of the enzymes that you will have to remember, at least 4 or 5 of it you have to remember. As I told you, if you cannot specifically remember which drug is inhibiting which enzyme, remember the general drugs. Similarly about inducers, you will find most of them. Fluoxetine is here also. Here you will find phenobarbital, carbamazepine, rifampicin in 2C8, 2C9 also, same inhibitors. Just specifically you can remember some of them, like here cigarette smoke in case of CYP1A2. So smoking also inhibits some of these enzymes. So these are the examples that you can specifically remember. And this is something like to remember: enzyme inducer, phenobarbital, phenytoin, carbamazepine, efavirenz, all of them, they are there. And what are they inhibiting? 3A4. And because of that, these are the drugs whose metabolism is being affected. So this much at least you should remember. All these drugs that I have, BPGC, NAIR, 3A4, and these are the drugs whose metabolism is affected. 2C9 Oral contraceptive is warfarin. So 2C-niacin is also oral contraceptive is the very common example that is given. So smoking charcoal 1A2, and this affects theophylline, warfarin, imipramine, paracetamol, neuroleptics also. So smoking has some interaction with these drugs that specifically you can remember. And chronic ethanol intake, this affects 2E1, affects the metabolism of ethanol itself. So these are two enzymes you can remember, 1A2 and 2E1. 1A2 is affected by smoking and 2E1 is affected by alcohol. Then we come to the reactions. Another important thing, which are the biotransformation reactions. Remember, broadly, biotransformation reactions are divided into two, phase 1 and phase 2. Phase 1 we say are non-synthetic reactions, phase 2 are synthetic reactions. Another way to describe them is phase 1 exposes, phase 2 disposes. Because in phase 1 reactions, the reactions takes place, they unhide some of the active parts of the drug, so that in phase 2 reaction, synthetic reaction can take place. So many questions about it also. Normally we say that phase 1 and 2 they happen sequentially. First there would be phase 1, then phase 2, but it is not a rule. Trend, it is normally it happens, but it is not necessary. A drug may be directly metabolized by phase 2 reactions. Directly there is conjugation, or a drug undergoes phase 1 and gets excreted, there is no phase 2 reaction. This may happen, but usually, as I told you, phase 1 exposes the active molecule and phase 2 attaches the synthetic compound with it. So it gets conjugated, and conjugated drug is water soluble, it gets excreted. So normally this happens. So which are the reactions? Remember 3: oxidation, reduction, and hydrolysis. Remember these 3 reactions: oxidation, reduction, and hydrolysis. Now these reactions can be microsomal and non-microsomal. Microsomal means in those CYP enzymes, and non-microsomal, which are non-specific enzymes present in cytoplasm, in mitochondria, or in some other parts of the body. They are non-microsomal enzymes. There are so many esterases, there are so many amidases. So there also it would be metabolized. All your neurotransmitters, they are metabolized not by microsomal enzymes, they are metabolized in the cleft only. So that is non-microsomal reactions. And when we talk of oxidation, one more thing you should remember: oxidation is not only attaching the oxygen molecule with the drug. Oxidation reactions are those where negatively charged molecules or compounds are attached to the drug. Oxygen is negatively charged, so if it is attached, then we call it oxidation. But it is not the only compound that is attached in oxidation. If we attach some other negatively charged, there are alkyl groups, there are amine groups, so many sulfuration, desulfuration. So this is oxidation reactions which can be microsomal, and amongst microsomal also aromatic hydroxylation. So here what is attached is OH group, OH minus we write, isn't it? So hydroxylation, remember one I told you, hydrolysis, that is different thing. In hydrolysis, water molecule is broken into H plus and OH minus. One of the compound of the drug will be with OH, another will be with H. That is hydrolysis. That is done with esterases and amidases. Breakdown of a molecule with the help of water molecule, that is hydrolysis. Here it is hydroxylation means attachment of OH minus group. Examples of this, just like I keep telling you, remember the examples. Classical examples: phenobarbital, phenytoin. Aromatic means this structure R followed by this. One hydroxyl group will be attached to this. This simplest thing I have described. This is how it happens. Hydroxyl group is attached with this aromatic ring. So this is aromatic hydroxylation. This is aliphatic hydroxylation. So here RCH2CH3, there is no aromatic ring. Remember, it does not mean that this drug does not have aromatic ring. This may be a side chain of this drug, but in the side chain, when OH is attached, then we will call it aliphatic hydroxylation. Again, examples are same: phenobarbital, digitoxin. One drug may be metabolized by more than one type of reactions. It is rather a rule. It's not that if aromatic hydroxylation has taken place, then aliphatic will not take place. So at whichever place the reaction can take place, it will. So aromatic hydroxylation, aliphatic hydroxylation. Then comes dealkylation. NOS. Three types of dealkylation reactions take place in oxidation. N-dealkylation example I can give you: mifebarbital, morphine, amitriptyline. So what happens? This is the broadly what happens that I have shown. RNHCH3 is a molecule. So what will happen? RNH2HCH2. This CH3 is removed. So what it has become? One aldehyde and RNH2. Amination. It has taken place. Or if it is secondary amine, then something like this RNCH3 to RNHCH3, CH3CH2. So one CH3 is removed. One CH3 that was attached with nitrogen is removed. So we call it N-dealkylation. O-dealkylation. In O-dealkylation, the CH3 that was attached to O group is removed. Example is phenacetin to paracetamol, conversion of phenacetin to paracetamol, and another is codeine to morphine. Codeine to morphine, active drug is converted into another active drug. So codeine to morphine also, this is O-dealkylation. And then S-dealkylation, example is 6-methyl-thiopurine to 6-mercaptopurine. This we read it when we read anti-cancer and other drugs. So 6-methyl-thiopurine is converted to 6-mercaptopurine. So what is happening? The CH3 that was attached to sulfur group, it is removed. So S-dealkylation. So three types of dealkylation. NOS. Then two types of oxidations, N and S. So what is happening? Oxygen molecule is being attached. This is what we consider is oxidation. But this is not the only oxidation reaction. So N oxidation, like this, with N oxygen is attached. So these are the examples of that. Chlorpheniramine is metabolized, quinidine is metabolized, dapsone is metabolized by N oxidation. Similarly, S oxidation. With S, oxygen is attached, so SOs will be formed. Examples: chlorpromazine, cimetidine, they are metabolized by S oxidation. So two types of oxidations we'll have to remember. Then deamination. NH2 is removed, NH3 is removed, and what remains is one of the amine group is removed. So these are the examples: amphetamine to phenylacetone. Deamination, there are so many examples of deamination. So deamination is another oxidation reaction. Then desulfuration. Desulfuration, S is removed. Desulfurization, S is removed and replaced by oxygen. Parathione to paraoxone. This is another classical example. Parathione is metabolized by desulfurization. So these were microsomal enzyme oxidation reactions which I told you. Aromatic hydroxylation, aliphatic hydroxylation, NOS, 3 types of dealkylations, NSS oxidation, deamination, desulfurization. These are the oxidation reactions, microsomal. Then there are non-microsomal cytoplasmic oxidations. Same thing, it's just that it is not happening in the microsomes, it is happening in the cell directly. Alcohol to alcohol dehydrogenase, aldehyde dehydrogenase, that is also oxidation reaction, but that takes place in cytoplasm. Plasma oxidation also takes place. Example is xanthine oxidase से histaminase. Histamine is broken down into imidazole acetic acid, or xanthine is converted to uric acid. This happens in plasma. So plasma oxidation. So in oxidation you remember these examples. Then we come to reduction. Reduction reactions are nitro reduction and azo reduction. Remember these two. Nitro reduction means something like this. RNO2 is converted into RNH2. Oxygen is removed, replaced by hydrogen ion. That is reduction. Na? Positively charged hydrogen ion is taken by the drug. So NO2 is converted to NH2. This is hepatic nitroreductase plus FADH. Normally in these reactions you will find FADH or NADPH. They are involved. They provide the hydrogen ion. Example are chloramphenicol to arylamine derivative. So this is nitro reduction. This is azo reduction. Prontosil, sulfasalazine. So what happens here? Something like this, NR, NR1, something like this. So what happened? RNH2, R1NH2. So both this bond is broken between NN and both are replaced with NH2. So this bond is broken with the help of hydrogen ion. So we call it azo. This is azo bond basically. So azo reduction is when this bond is broken with the help of hydrogen ions. And example of this sulfasalazine, prontosil. Actually prontosil was converted to sulfonamide. Prontosil is a prodrug, the classical example of sulfonamides. Prontosil was actually used as a sulfonamide in the beginning when the antibacterial activity was found out. Keto reduction. This is keto group, CO. This is broken and replaced with CHOH. Example I can give you: cortisone to hydrocortisone, methadone, naloxone, all these are. So this is keto reduction. The keto group is broken with the help of hydrogen ion. Here actually one OH group is also involved. So water, H2O is added. So this is keto reduction. So you have nitro reduction, you have azo reduction, you have keto reduction. And non-microsomal reductions, chloral hydrate is converted to trichloroethanol. This is an example of non-microsomal reductions. Then hydrolysis, rare. Microsomal hydrolysis is not, it's a very rare phenomena. I could find this example of pethidine and lignocaine, but that is also not very common. They are mostly non-microsomal. As I told you, esterases, amidases, they are all non-microsomal. All these examples: procaine to PABA, plasma choline to esterases, this atropine to tropic acid, penicillin, procainamide. These are, wherever you find this esterase is involved, amidase is involved. So that means it is non-microsomal hydrolysis is taking place. So these are phase 1 reactions that you can, not much actually, if you this is endless, but what I have taken are very important: oxidation, reduction and hydrolysis. Then we come to phase 2, synthetic reactions. In synthetic reactions, most common is glucuronide conjugation. So this is how it takes place. The drug uridine diphosphate glucuronic acid with the help of microsomal glucuronide transferase enzyme, drug glucuronide combination is formed and UDP is released. This is most common phase 2 reaction. You can give any number of examples. All these drugs are excreted by glucuronide conjugation. Actually, glucuronide is like a carbohydrate, C6H9O6. This is an example I have taken. Salicylic acid can be converted to ether glucuronide and some of it can be converted to ester glucuronide. So if this glucuronide is attached to this OH part, then it becomes ether glucuronide. If it is attached to COOH part, it becomes ester glucuronide. So it is a carbohydrate like structure. So this makes the drug very water soluble. Non-microsomal conjugations. There are many of them. N-acetyl conjugation, this occurs in cytosol. N-acetyl transferase, we have heard this enzyme again and again, with the help of acetyl coenzyme A. Very common reaction. Example: isoniazid, PAS, Depson, procanamide, all these are N-acetylation. We hear so many times. N-acetylation takes place. So two things are involved. One is acetyl coenzyme A and N-acetyl transferase. Sulfate conjugation. Sulfate group is attached with the help of sulfotransferase. Examples again: methyl dopa, hydroxycoumarins, corticosteroids, chloramphenicol. So sulfate SO4 is attached with the drug. So sulfate conjugation. Amino acid conjugation, glycine, glutamate, they are converted. So something like this, there has to be one carboxylic group, RCOOH, and with this coenzyme A is involved and amino acid synthetase is involved, and mostly, as I told you, glycine or glutamate, they are the amino acids which are conjugated. So many of these drugs, benzoic acid, aspirin, deoxycholic acid, nicotinic acid, they are bound with glycine or glutamate. So that is amino acid conjugation. Methyl conjugation, it takes place in cytosol. Some of the examples you can remember: catecholamines, histamine. Catecholamines degradation we all know with the help of this reaction, COMT, catecholomethyl transferase. So I don't think all of us we have read about degradation of catecholamines. So that is same methyl conjugation with the help of COMT, catecholomethyl transferase. Glutathione conjugation specifically. Glutathione is 3 protein combination: glutamate, cysteine and glycine. So this is attached. There are so many examples with the help of glutathione S transferase. So glutathione conjugation you will have to remember. And riboside phosphate, rarely in anti-cancer drugs. This ribose phosphate is conjugated. So in conjugation, in microsomal glucuronide conjugation. In non-microsomal, all these N-acetyl conjugation, sulfate conjugation, glutathione conjugation, amino acid conjugation, you remember these are conjugation reactions. Then what is the clinical importance? We all know, just the thing is that we have to compile it together. It reduces therapeutic effect. If the drug is fast metabolized, then naturally therapeutic effects will be decreased, and Example, rifampicin reduces effect of oral contraceptives, classical example. Actually, this is given again and again. Phenytoin reduces warfarin effect, so risk of thrombosis. So this becomes important when we are giving chronic therapies. Auto-induction, I was giving some examples. So in those cases, you have to adjust the doses of those drugs. Carbamazepine dose needs gradual increase because this auto-induces itself, its breakdown. Increases toxicity of prodrug. Suppose the prodrug you were taking and this was maintaining some level of active drug. Now what will happen? Paracetamol is there. Toxic metabolize NAPQI. So if the enzyme induction takes place, then what will happen? More of it will be generated and there will be more toxicity. One more thing you should remember, enzyme induction is very slow. Inhibition takes place very fast, within hours. But induction is slow because in inhibition we do not differentiate between two things. In induction, remember, activation is different, induction is different. Activation is the activity of the enzyme is increased. The Km, Michaelis-Menten constant, it changes. The same amount of enzyme will produce more metabolites. This is how we measure Michaelis-Menten equation. The same amount of enzyme will produce more metabolite with the same amount of substrate. That is activation. In induction, this is not happening. The activity of enzyme remains same. The amount of enzyme increases in induction. More amount is produced by the microsomes. So there is a difference between activation and induction. In induction, the Km remains same, constant. In activation, Km changes. In inhibition, we do not say this. Inhibition is basically reverse of activation. There is hardly any effect on production of enzyme. The activity of enzyme is reduced. So always remember this thing. That is why inhibition is very fast. And for induction, this will take place only when the changes in nucleus they take place. More enzyme needs to be produced. So this also will have to remember. Tolerance development. If the drug is metabolized faster, naturally the effect will decrease. Phenobarbital, I was telling you, sedation decreases over time. We all know if you keep taking barbiturates, benzodiazepines, then gradually the effect is not there. You have to increase the dose. Endogenous substances also. Induction can increase metabolism of steroids, vitamin D, and because of that thyroid hormone. Because of that, what will happen? Osteomalacia for long time. There may be hormonal imbalances. So there may be changes in metabolism of our own. And clinical uses, we can use this also. Example, we classically give example, we give phenobarbital if there is neonatal jaundice, because we want to induce the microsomal enzyme system so that bilirubin can be conjugated and excreted. So this is the utility. Then inhibition also. Drug toxicity. Example, erythromycin plus theophylline. Theophylline toxicity will take place, arrhythmia, something like that, because erythromycin is inhibiting the enzyme. So theophylline toxicity will increase. Fluconazole will increase the toxicity of warfarin, will increase the activity of warfarin. Becomes very important when warfarin is a narrow therapeutic index drug. And say this increased prolonged drug effect. Again examples we can give diazepam. If you give in presence of enzyme inhibitors, then there will be excessive sedation. Reduces activation of prodrug. If the prodrug is not converted into active drug because of enzyme inhibition, the effect will not be there. Enalapril, activation may be reduced, so effect of enalapril will be decreased. Clopidogrel efficacy reduced by enzyme inhibition. And clopidogrel is very important. I won't say narrow therapeutic index drug, but the effect will be there when antiplatelet activity is decreased. Therapeutically, we can use it. Ritonavir inhibits CYP3A4 to boost other protease inhibitors. Allopurinol reduces uric acid formation in gout. So these are benefits that we can take. If first pass metabolism is reduced, then it will be beneficial. And which are the factors which affect biotransformation? Remember, none of them is very significant. They are just for the sake. But if somebody asks you, you have to write something. Say I give you example of age. I can only enumerate gray baby syndrome. In neonates, biotransformation is less. So what happens? Gray baby syndrome is the example of that. When we give chloramphenicol, it is not metabolized. So in neonates, biotransformation is not that developed. Similarly, we can say in elderlies, because the blood supply to liver decreases, and because of that, some of the drugs, say propranolol, tolbutamide, they will be metabolized less. In gender, again, theoretically, we can give you some examples, and there are some differences. Like in animals, we have done experiments in this hexobarbital. There is more effect on female rats. Males, they sleep for a lesser time. So in males also, this may be, this effect in human beings also may be there, but nothing is proven. But just for the sake of it, you can remember there may be gender differences. I am giving example of rats. Male rats, they sleep for a lesser time compared to female rats. Species, again, we can find out some, because but ultimately we are talking of human beings. We cannot be many species. But say atropine is metabolized faster by rabbits. We can give examples that some species of animals, they can metabolize some drug more faster or slower. So this example of rabbit is given. Race, again we can find out. I was reading like in Chinese, alcohol dehydrogenase is more, aldehyde dehydrogenase is less. Because of that, they accumulate aldehyde dehydrogenase in the body, not able to metabolize it. So some racial differences are there. Genetic variation, we all know, fast acetylators and slow acetylators. So that is a fact that affects this, we can underline. And diseases, again, yes, if there are liver diseases, there is liver cirrhosis, there is hepatitis, or in some cancer, hepatocellular carcinoma, if the biotransformation capacity of the body is decreased, then naturally there will be less biotransformation. So these are the effects which take place. So we will stop it here. Next time we will talk about excretion. ठीक है.